Patients are told to be good consumers, but we're navigating a system that isn't exactly user-friendly. Have you ever looked at a hospital bill and been aghast at how expensive and incomprehensible it was? Or tried to figure out which healthcare plan to choose and played the odds about whether you should go for the high-deductible plan or not? The new book, An American Sickness, explains how healthcare became big business and how the pricing and billing of medical services, devices, and prescription drugs became so complicated, even a lot of doctors don't understand it.
One expert in the book joked, if we relied on the current medical market to deal with polio, we would have iron lungs in 7 colors with iPhone apps.
This is Fresh Air. I'm Terry Gross. My guest is the author Elisabeth Rosenthal, editor-in-chief of Kaiser Health News. When she was a reporter at the New York Times, she wrote a series called Paying Till It Hurts. Before becoming a journalist, she was a physician. Why did you leave medicine?
In 1994, I was working in an emergency room in New York City, and I saw a lot of problems with our healthcare system. If we remember what was going on in 93, 94, Hillary Clinton was proposing a healthcare reform plan. So I initially converted to journalism at the invitation of some editors at the Times to cover the Clinton health reform. And I honestly always thought, okay, I'll do this, I'll cover medicine, I'll cover healthcare reform, and it'll be done, and then I'll go back and be an ER doctor and I'll be happy. And of course, the Clinton health reform didn't pass. And here we are more than 20 years later talking about the same issues, only more so. And I think that's what drew me back to healthcare reporting was I saw all the same issues, but in such an exaggerated form. When I was drawn to journalism to write about healthcare reform in the 90s, at that point in time, healthcare was still pretty much working for the upper middle class, people who were insured, for physicians. It was okay.
It wasn't working for the people I was seeing in the emergency room.
People with HIV/AIDS, people who were poor. After years as a foreign correspondent, when I came back to the U.S., my aha eureka moment was, hey, this system isn't working for anyone now.
This system isn't working for anyone now.
There's still a lot of proponents of single payer. Are you one of them?
Single payer has certainly worked in many other countries. Other countries have used market-based solutions and gotten really good health care too. If you look at Switzerland, they have a largely market-based system, but all the countries that have working marketplace systems have some form of control over pricing. It's not the Wild West open market. They'll say, this is the ceiling you can charge for that procedure. They'll say, this is a bandwidth in which you can charge, and you can compete all you want below that ceiling or within that band. But you can't just drive up prices to whatever the market will bear. One of the legitimate analogies is if water or electricity was a totally free market, imagine what prices would be like.
In Australia, doctors have to obtain informed financial consent as well as medical consent.
What America could learn from it is possible. It's not like breaking a law of the universe. This is something that doctors do in other countries. It may be harder in our highly compartmentalized medical system, although more and more we're seeing procedures bundled, meaning having a flat all-in fee for everything you might need. Every patient is different, but on average, hospitals know about what they have to spend, so they could give you a pretty good ballpark. I know one patient, when she asked about the cost of pregnancy that she was paying out of pocket, got an estimate of between $5,000 and $45,000. I don't know how you can act on that. Yes, there are extremes, but they know pretty much what the ballpark is. And more, maybe we should be asking them to pay that bundled fixed fee that's the ballpark, and it's their problem that some go way over and some go under. That's what Medicare does for hospital payments, and it's worked pretty well for Medicare. It can be done. It's just that we have not put pressure on our hospitals, our providers, and on our insurers to think that way.
The premise of the competitive market is that we'll be shopping for the hospital or the doctor that does the procedure cheaper.
This concept makes me a little nuts, frankly, because there's lots of competition. We're told over and over again, you should be a good consumer of health care. What do you need to be a good consumer? You need to know a price. And say my doctor tells me you need to get that wrist x-rayed after you fell. I may call 10 x-ray centers. No one's going to tell me the price. They're all going to say it depends on your insurance or we don't know. So how can I shop around even in that kind of elective situation? I can't really shop because I don't know the prices. And P.S. a lot of medicine isn't so elective. Your doctor says you need to have your hip replaced, or I'm going to fill out a requisition for this blood test. Here's the lab I'm sending it to. You don't have a lot of choice. Now, part of what I'm saying is you should ask for that choice. If your doctor says, I'm going to order this blood test and here's the lab you should go to, it's beholden on us now to say, which labs are in my network, because I don't want to be hit with an out-of-pocket cost for that test.
Let's start with some of your economic rules of the dysfunctional medical market. You say more competition doesn't mean better prices. In fact, it can drive prices up.
What we see in healthcare is not like what we see in any other economic market. It's sad, it's amusing, it's baffling. Look at drug prices, for example. There was a miraculous drug called Gleevec, which really changed cancer patients' lives when it came out, maybe 10, 15 years ago. Now there are many, many kind of copycat versions. We call them sons of Gleevec. And they're all 4 or 5 times more expensive than Gleevec was when it came out. You would think there are 10 of these now, so the price should have come down. It hasn't. Because the standard in healthcare has been usual and customary. So that kind of doesn't let the market work. You may have seen that on your insurance bills, or you may have seen that when your insurer is saying, this is how much we're going to pay. It's the usual and customary in your area. Well, what happens if everyone is charging 5 times as much as is reasonable? 5 times as much becomes usual and customary. And it's a very inflationary concept over time. So what you see because of usual and customary is that maybe a gallbladder operation will cost $50,000 in Nassau County on Long Island, but it might cost $10,000 5 miles away in Queens, and that's because the usual and customary in those two geozips are very different. That's the ultimate lesson of much of American healthcare, is that prices rise to whatever the market will bear. And another concept that I think is unique to medicine is what economists call sticky pricing. And you see this over and over again in the drug sphere and also in the hospital charge master sphere. Maybe it was $5,000 2 months ago. But once one drug maker, one hospital, one doctor says, hey, we could charge $10,000 for that procedure or that medicine, the prices all go up to that sticky ceiling. What you see often now is when generic drugs come out, the price doesn't go down to 20% of the branded price. It maybe goes down to 90% of the branded price. So we're not getting what we should get from a really competitive market where we, the consumers, are making those choices.
Another one of your economic rules of the dysfunctional medical market, a lifetime of treatment is preferable to a cure.
You've got to look at every medical problem from 2 sides, what's right for healthcare and what's good for business. We've trusted a lot of our healthcare to for-profit businesses, and it's their job to make profit. Much as that makes me uncomfortable, if you're a pharmaceutical manufacturer, if I invented a pill tomorrow that would cure diabetes, that would kill a multi-billion-dollar business market. It's far better to have treatments, sometimes really great treatments, very effective treatments, but you kind of want the treatment to go on for life. One expert in the book joked to me that if we relied on the current medical market to deal with polio, we would never have a polio vaccine. Instead, we would have iron lungs in 7 colors with iPhone apps. iPhone apps.
One of the things I've been noticing is the consolidation of hospitals, where one entity will buy up a bunch of hospitals in the region, and the hospitals maintain their name, but they're all under a larger entity. What's that about? Why is that happening?
In many cases, it's not very efficient to have a huge number of hospitals scattered in every little town. In the beginning, this was a good idea. Hospitals came together to share efficiencies. Now, that consolidation trend has kind of snowballed and skyrocketed. So to a point now, in many parts of the country, major cities only have 1, maybe 2 hospital systems. And what you see with that level of consolidation is it's kind of a mini monopoly. And when you have a mini monopoly, you have an enormous sway over price. So what we see in research research over and over again is that the cities that have the most hospital consolidation tend to have the highest prices for health care without any benefit for patient results.
There are so many shopping plazas now that have a dialysis center and an imaging center. What's going on there?
The idea was in the 80s and 90s that a lot of things that used to be done in hospitals could be done as outpatients. That's far more convenient for patients if you don't have to go into a hospital. So there was a movement of a lot of things to outpatient status. Also, anesthesia got better. We could do much more under local. But what's happened is it became a revenue source. So a lot of these outpatient clinics became owned by doctors who were doing the surgery. So there was a kind of mixed motivation in, do you need the surgery and I'm making money from this surgery? So when your doctor says, okay, you need a colonoscopy, we can do it on either Tuesday, I'm doing it at my surgery center, or Thursday where I do them in the hospital. For patients, that can mean the difference between an outpatient procedure, which may cost you $5,000, and a hospital outpatient procedure, which will be billed perhaps at twice as much because you're paying for hospital OR time. So there's a huge price implication for patients, and often patients aren't told that. So you may just say, oh, I'll have it done on Thursday, that's my day off, and not knowing that it's going to cost you twice as much. It almost always will because you're paying a hospital fee. Mm-hmm. On the other hand, I think there's an upside and a downside. If you're having a serious medical procedure in a surgery center, maybe it can't handle emergencies that a hospital could handle. So, there are things that need to be done in the hospital and there are things that can be done in surgery centers. That decision, I think, sadly now is often made as the result of a trade war between those two entities rather than really what's best for a patient. There's a big push to do more and more as an outpatient, and there's a big debate in the medical community about whether we're trying to do too much in the outpatient setting now. The push is partly from the health insurance companies because it's lower cost. It's driven largely, though, by the people who own the outpatient surgery centers, of course, the ones you see advertising on TV and in shopping malls, because they want the revenue. So the hospitals as a whole don't like it. But in the latest twist of this ongoing consolidation of financial power, many of the hospitals have decided to end this trade war with the outpatient surgery centers and are just buying them up. So the thing in your shopping mall that looks like an outpatient surgery center is now actually rebranded as being the hospital. Even though it's the same surgery center in the same shopping mall, they'll just say, oh, it's now part of our hospital network. So now that same surgery center will charge hospital prices.
In some ways, the consumer/patient can't win.
When you're in the hospital, that nice doctor who stops by every morning and says, how you doing, might end up charging you like $700 for each time he stops by.
For each time he stops by. For each time he stops by.
And you don't know about that. How you doing? $700. How you doing? $700. How you doing? $700. You call that drive-by doctors.
Sometimes they're there because your primary doctor asked them to be there, and your primary doctor probably isn't thinking, that's going to be a big bill for my patient. They're just thinking, well, she's in the hospital anyway, it'll be useful, but consult in the hospital is going to be really, really, really expensive, and there's a good chance you're going to be paying for it, or your insurer's going to be paying for it, and we'll all pay. In other times, it may be the hospital who's assigned that person to come by. There are hospitals now who say every patient before discharge has to have a physical therapy consult. I would say some of this is motivated by billing. Over and over again, what I hear from patients who look at their bills, that physical therapy consult was just someone who came by and walked with me down the hall. That wasn't a consult, that was 5 minutes, and there's no way that was worth $600. You do have to say, who are you? Who called you? And am I going to be billed for this? In places where it's just mandatory for discharge, I've gotten complaints from heart surgeons who say, I know when my patient needs a physical therapy consult and I'll order it if they need one. I don't want it to be the kind of automatic checkbox for everyone. It's just not necessary. It's tragic that in recovery, people have to think in this keep on your guard adversarial way. But if we don't push back against the system and the way it bills, we're complicit in allowing it to continue. Start every conversation with a doctor's office by asking, is there a concierge fee? Are they affiliated with a hospital? Which hospital are they affiliated with? Is the office considered part of a hospital, in which case you're going to be facing hospital fees in addition to your doctor's office fees? You ask your doctor always, as I do mine, if I need a lab test, if I need an x-ray, will you send me to an in-network provider so I don't get hit by out-of-network fees? Our insurers have deals with certain laboratories and certain x-ray chains, and if you stay within that chain, you'll be largely protected from costs. If you go out of it, you can be hit with big costs. And often that will be a little hard for your doctor because they may have to fill out a different requisition, but it's worth asking, and any doctor who won't help you in that way, I think, isn't attuned to the financial cost that we're bearing today. When your doctor suggests, why don't we just get this test? Ask why. How will it change my care? Because often doctors are ticking off boxes on a long checklist of tests, and maybe they're not thinking, do I really need that one? Often a bunch of them come together, and maybe these days with electronic medical records, a lot of them are automatically checked off. The doctor may have to uncheck tests. Help your doctor be more attuned to your financial needs.
You suggest that if you're in the hospital for any reason, you need to ask whether you are officially under observation or whether you are being handled as an inpatient.
The difference between inpatient admission and under observation status is huge in terms of the finances. It's not any different in terms of what you see as a patient, and that's why you're so at risk, because you'll be moved to a hospital bed, you'll see the same doctor, you'll get the same test, but technically you're not admitted to the hospital. And that has a huge implication for what you're expected to pay, because observation status is technically, for financial purposes, outpatient care, which means the terms of your outpatient insurance applies. That means you're responsible for co-payments that may be up to 20%. And 2 days in a hospital, 20% co-payment, you're easily into the thousands, if not tens of thousands of dollars. Also, if you're a Medicare patient, Medicare will cover your nursing home care if you're transferred out of a hospital after admission. If you're under observation status, they'll say, you don't really need nursing home care. You were never really in the hospital. So you always have to ask. When my mom was admitted to a hospital in New York a couple of months ago, after, is she okay? The next question was, she's not under observation care, is she? She's admitted, because I know the vulnerabilities of that. And that's the problem with our health system. If you're a person who's really sick, you're not thinking, oh, am I going to be able to pay this in 2 months? You're just thinking, I feel awful. I want to get better. Am I going to die? So it's always helpful to have someone who can serve as an advocate for you in the hospital while you're there.
It's kind of a sad reflection of our system.
Another question you suggest is, who else will be involved in my treatment? And will I be getting a separate bill from another provider?
There's been a lot of talk lately about surprise medical bills, and I'm really glad that one of the articles in the New York Times series about a young man who went in for neck surgery at a hospital in New York and ended up being billed $117,000 by an assistant surgeon who he'd never met, and it was out of his insurance network, helped ignite that discussion. He was asleep in the OR, so he had no idea this guy was in the OR. When he got the bill, he flipped out and thankfully called me at the New York Times then to talk about it. So I think we are all vulnerable to surprise medical bills. You go to an emergency room, you think everything's covered because it's in your network. But guess what? The doctor there may not be part of your network. He might call in a dermatologist who's not in your network because he just wants the dermatologist to look at a funny rash on your shoulder. Little things like that. And so you have to ask, who's going to be involved in my care that you're not telling me about? And you have to insist that they be in your insurance network, because otherwise you can be on the hook for those really, really huge out-of-network charges. And to me, logically, you go to an in-network hospital, you go to an in-network emergency room, everything should be covered in-network. But that's not how the system currently works, so you got to watch your back.
I'm not sure patients are in the best position, even if they're alert, to evaluate what care they need and what care they don't. Something that you can't really do when you go to the hospital, say, how much is this going to cost me? You'll be told, I don't know, it depends on how it goes.
You have to be a good consumer and say if what the physical therapy consult is going to involve is walking you to the bathroom, you can say, oh, thanks, but I've already done that and I'm fine.
I want to ask you about coding, the letters and the numbers that are used in the doctor's office to codify for billing purposes. It's really complicated.
It evolved from a good idea and got perverted into something that is really kind of toxic if you think of healthcare as a market, I think. Coding systems originally evolved during the bubonic plague in order to classify diseases. And, there were a lot of people dying in different countries, and you wanted to be able to track disease epidemiologically. Now, in the U.S., and I believe only in the U.S., these coding systems became the bedrock of medical billing. So you were billed according to what the ICD code was for your disease. And at some level, that makes sense. Rather than write out pulmonary hypertension with grade 3, blah, 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 you just put 107.2. That made sense. Once that coding performed a bedrock financial function, like all the rules on Wall Street for markets, over time, people learned to manipulate it. And other codes developed because codes were kind of vague. They just said what disease you have. But if I'm a doctor, I do a lot of different kinds of things for different diseases that I want to bill for. So then you need a coding system for what doctors do, which is called the CPT code, and those are owned by the American Medical Association. So there's a little bit of conflict of interest there. So you have the CPT codes for doctors. What about when you're in the hospital? You need a different kind of code for all the stuff that's done there because everything is billed item by item in the hospital for most commercially insured patients. There'll be oxygen per 15 minutes, $100. Recovery room time per 15 minutes, $500. Tylenol, every little thing that's done to you is barcoded and charged and has a code. It's overwhelming, but you can figure out a lot. First of all, go back to the hospital and say, I want to know what I'm paying for. I want a fully itemized bill. Don't be alarmed by the prompt payment discount. Some of it will be in codes. Some of it will be in medical abbreviations. You can Google those codes. You might find you're being charged for stuff that you didn't have. Wanda Wickeser, the subject of a section of the book, discovered that in her $356,000 bill for her surgery, which was inpatient, she came into the hospital unconscious and was in the intensive care unit. There was something like $70,000 billed for outpatient surgery. She was never an outpatient. So that kind of thing you can pick up pretty easily. If your son didn't have a circumcision, you know that. Many bills have errors, and you'll find things that will save you money. More than that, I've seen patients who got bills that just said $76,000 you pay. No explanation of what it is you're paying for. Before the ACA, I heard from patients who had a history of mild depression or used an asthma inhaler and as a result couldn't get insurance. Whatever flaws you can point out, and there are flaws, the ACA guaranteed health insurance to people with pre-existing conditions. It also removed lifetime caps, which was really important to people with chronic diseases who might have maxed out their insurance coverage. And it also established health insurance as a right. And it insured 20 million more people. That being said, the ACA has its flaws. One of those is that the marketplaces are highly uneven in how well they function. Some have functioned fantastically. Some have been beset by huge premium increases. Others have been beset by insurers pulling out and saying, we can't make money doing this.
Overall, insurers are doing just fine.
Another thing is that the ACA struggled to become law and is less than the Obama administration had hoped it would be. So part of the distress we're seeing is that Congress did not come through for the ACA in the way that had been initially anticipated. Some of the money that had been promised to support the exchanges didn't arrive. It never was approved. So yes, some of the exchanges are having trouble. Some insurers are pulling out. But in essence, these marketplaces were trying to work often with one hand tied behind their back.
Elisabeth Rosenthal is the author of the new book, An American Sickness. How you doing? $700.
Apps.